clinical practice, we have all seen a number of patients who present with pain, numbness, tingling of the upper extremity, made diagnoses of tendonitis, bursitis, epicondylitis. These people have dysfunctions in their upper extremity, and they frequently present as a diagnostic and therapeutic challenge. I would like to provide for you a model that I have found useful in dealing with those people. It begins by being sure that the cervical spine and upper rib cage is functional because of the influence of that on the brachial plexus, the neurovascular bundle, as it begins to course down into the upper extremity. We would look at the upper extremities and the multiple joints involved in that, and we begin with our patient doing a screening examination. We did this once before. Mark, just take your hands to the side, then take them right out to the side, right up over to the top of your head. Try to put the backs of your hands together. That screening procedure requires good function of a number of different joints in the upper extremity. Okay, you can put it down, Mark. Now, what are all those joints? The sternoclavicular, the acromioclavicular, the scapulocostal. That really isn't a true joint, but the scapula must move on the rib cage during the abduction movement of the upper extremity. The glenohumeral joint, the elbow joint, and there are more than one at the elbow, and the wrist and hand, and there are multiple joints within the wrist and hand. Starting at the most proximal, the sternoclavicular joint, it has a cartilage within it, a little meniscus like the knee, and its motions that become dysfunctional are primarily those of abduction movement and horizontal flexion movement. Diagnostically, we will place our hands overlying the medial end of the clavicle, and we will ask our patient to shrug their shoulders. Then we will put our hands on the anterior aspect and have them reach forward in horizontal flexion. On our patient, it would look like the following. The diagnosis of abduction restriction of the sternoclavicular joint is done by placing a pair of fingers on the medial end of the clavicle and asking the patient to shrug their shoulders toward their ears. Shoulder up and down. What we're looking for, the normal behavior is that the medial end of the clavicle goes caudad during the abduction shrugging maneuver. Once more, and down. In this instance, we have some restriction of the left sternoclavicular joint to go into abduction movement. Shrug your shoulders one more time. It goes more cephalward because of the restriction of abduction movement. Down again. Now, to treat that dysfunction with muscle energy procedure, we will ask Mark to slide over to the edge of the table. I will control his upper extremity, internal rotation of the extended arm, monitor over the medial end of the clavicle at the sternoclavicular joint, but I'm also going to be maintaining a compressive force caudad on the medial end of the clavicle. We drop it down till we meet the first barrier to clavicular movement, hold compression on the medial end of the clavicle, and ask Mark to lift the back of his hand toward the ceiling. Lift it up. We resist that. Relax. One more time. Lift. Relax. Lift. Relax. Notice that I can drop this arm down farther after each effort. One more time. And relax. Back to the midline. Let's reevaluate. Hunch your shoulders to your ears and down. Seems to move better. Now, not only does that deal with the abduction motion restriction, but some of the rotational motion of the clavicle essential for arm abduction movement. The other motion restriction that can be present is the horizontal flexion, and the diagnosis is made by asking Mark to just hold his hands toward the ceiling, just gently. Palpate the medial end of the clavicle and ask him now to reach toward the ceiling. Reach up and down. Normally, both clavicles will, the sternoclavicular joint, the medial end of the clavicle, will go posteriorly. If one is held in front and does not move posteriorly, that's the restricted side. Once more, reach to the ceiling and down. That's not too bad on Mark, but there is a little bit of horizontal flexion restriction on the left side as well. The treatment procedure will include a contact on the medial end of the clavicle with a pisiform bone to hold it posteriorly while we resist the effort of the clavicle to move into horizontal extension. And that is done by having Mark hold the back of my neck, keep this elbow straight. I control his shoulder girdle by grasping the scapula. Put the contact on the medial end of that clavicle with this pisiform. I take up the slack by lifting up of my neck. Now pull down on me, pull. And stop. As he pulls down, the clavicle attempts to come forward, and I maintain it posteriorly to enhance its capacity to horizontally flex. Take up the slack, pull down again. Relax. One more time. Relax. We would then ask Mark to again reach toward the ceiling, push, to see if we have better symmetry, down, of horizontal flexion of the sternoclavicular joint. When we've restored function to the sternoclavicular joint, we now can evaluate and treat any dysfunction present at the acromioclavicular joint. The acromioclavicular joint has only a small amount of motion that it contributes to arm abduction. But if lost, it is very significant in restricting the whole shoulder girdle from going into abduction. To make a diagnosis of acromioclavicular dysfunction, one palpates over the joint. That's found by going from the lateral aspect of the acromion process around in front. You find a little groove, come up on top of that. Sometimes it's a groove, sometimes it's a little bump. But there is a palpable plane of the joint, and that joint radiates, and that joint angles anteromedially in about a 30-degree angle on each side. By palpating in that joint, and then by introducing arm abduction at approximately a 30-degree anterior angle, in this fashion, we can monitor the abduction capacity of the acromioclavicular joint. It has two other significant motions that, if they are lost, will reduce the ability to abduct at the acromioclavicular joint. Those are internal rotation and external rotation. You're using the glenohumeral joint as a lever arm to move the acromion on the lateral end of the acromioclavicular joint. So we will monitor over the joint, abduct the arm in that fashion, externally and internally rotate, constantly monitoring. And you compare both sides. Monitor in the joint. Take the arm out to the side. In abduction, you should feel a little V-ing motion. In other words, the acromion should go up in relation to the lateral end of the clavicle. Then test for its capacity to externally rotate and to internally rotate. Notice that, if you will, that the arm is carried about 30 degrees forward and doing this maneuver. It doesn't come out straight at the side. Testing the right side, monitoring the joint. Abduction. Seems to be a little restriction of abduction on this side. External rotation, that's not too bad. But internal rotation seems to be restricted. In range, quality, and feel. To treat the restriction of internal rotation of this right acromioclavicular joint, we will support his arm, take it forward to 30 degrees, monitoring at the acromioclavicular joint, internally rotate it till we find the first motion barrier. Holding it there, we're going to ask Mark to take the back of your hand up toward the ceiling. Lift, relax, increase the internal rotation, lift again, relax. One more time, lift, relax. After each effort, we increase the internal rotation, engaging each successive barrier to that movement. One more time, relax. Had we found some restriction of external rotation, principles would be only to hold his arm into the external rotation, and now with supporting his whole forearm, I will ask him to take his hand and pull it down toward the floor. Pull down toward the floor and stop, and repeat that a series of times. In Mark's instance, his restriction was on internal rotation. After having treated both the internal and external rotational components, then we want to just finalize the treatment of the restriction of abduction by putting both hands on the lateral end of the clavicle, engaging the abduction barrier. Pull your elbow right to your side. Relax. Pull it down. Relax. And we felt some increase in motion of abduction movement at that time. Now go back and evaluate. That moves quite well. Improved motion of internal rotation and abduction of the acromioclavicular joint. The glenohumeral joint is a polyaxial joint that has very little joint congruity to relate to its stability. Primarily, the stability of the joint is the rotator cuff, which is also its primary mover. The motions present in the glenohumeral joint are neutral flexion and extension, neutral internal and external rotation, abduction, horizontal flexion, horizontal extension, and internal and external rotation in the horizontal position. So those are the motions that we will want to test, and if we find restrictions, we will use muscle energy technique because of the influence on that rotator cuff for restoration of more motion. We will stabilize the clavicle and the scapula with one hand so that we can control the patient's arm and find the range of neutral flexion, neutral extension, neutral external rotation, and then neutral internal rotation, then abduction, horizontal flexion, horizontal extension, horizontal external rotation, horizontal internal rotation. This testing maneuver looks similar to that which we did for the acromioclavicular joint, but at this time we're doing it at 90 degrees rather than the 30 degrees anterior direction we did for the acromioclavicular joint. When you take the arm into abduction straight out to the side, it close packs the acromioclavicular joint so that the primary motion you're testing now is glenohumeral. We would compare that with the opposite side, stabilizing the clavicle and the scapula, neutral flexion, neutral extension, neutral external rotation, internal, abduction at 90 degrees, horizontal flexion, horizontal extension, internal rotation, and external rotation. We want to maintain symmetry of this and maximum freedom on either side. A nice muscle energy treatment sequence can be done in the following fashion. Stabilizing the acromion and the scapula, take it into horizontal, take it into neutral flexion, resist that by push your elbow back toward me, stop, next barrier to neutral flexion, push back, stop, and push again, stop. For neutral extension, take the elbow back, slide your hand behind, stabilizing it against the back of the patient's chest wall. Pull the elbow straight forward, stop, straight forward, stop. For external rotation restriction, put our hand against it, stabilize against his chest wall, to the barrier, pull your hand towards your stomach, pull, stop, pull, stop, pull, stop. Notice we increase the range after each effort, engaging the next barrier. For neutral internal rotation, we put his hand behind his back, stabilize the shoulder, push the elbow back to me, push, stop, push, and stop. In horizontal flexion, pull your elbow back to me, stop, again, stop, again, stop. Horizontal extension, pull your elbow forward, stop, pull, stop, and pull, stop. Horizontal external rotation at 90 degrees, pull your hand forward, stop, forward, stop. Horizontal internal rotation, similar to the acromioclavicular, but again at 90 degrees instead of the 30 degree forward. Back of the hand to the ceiling, stop, back of the hand again, stop. And then the final one is that which we must have at the glenohumeral joint, which is the abduction movement. Underneath the arm, stabilizing the clavicle and the scapula at 90 degrees, pull your arm down to the side. Pull, stop, pull, stop, pull, and stop. Then we would go back and reevaluate the range of motion right side to left side to maximize symmetry of range on both sides. Evaluation of the elbow includes 3 bones and 3 joints. We have the 3 joints of the ulna and the humerus, the radius and the humerus, and the radius and the ulna at the proximal radio-ulnar joint. Our primary motions here are flexion and extension, pronation and supination, and there's a small amount of medial and lateral joint play within that complex. For practical purposes, we deal with the pronation, supination motion and its restriction, and the restriction of elbow extension by restoration of normal pronation and supination and elbow extension. We restore most of the function to all three of those joints. Evaluation is made by keeping the arms to the side and controlling the lower forearm, taking the elbow into supination and pronation, sensing for range, quality of movement during the range, and end feel. One of the more common restrictions is supination restriction. To treat that, we stabilize the elbow at 90 degrees with one hand, introduce supination to the first barrier with the opposite hand. By holding the distal radius and ulna, we resist the patient's attempt at pronation. Turn your palm down and relax. Take up slack, pull down, relax, palm down again. Relax. Again, 3 to 5 episodes are about all you need to do to increase supination. Had there been pronation restriction, you just engage the pronation barrier in the same fashion with the instructions now to the patient. Turn your palm up. Relax. You're resisting a supination effort by the patient. One more time. Turn it over and stop. Once the pronation and supination motion at the elbow region has been restored, then we want to be sure we have full elbow extension. If we have resistance of elbow extension, a post-isometric treatment would be to take it to a barrier to extension, stabilize the distal forearm, take your hand towards your shoulder, pull it up isometrically, the biceps is contracting, stop, post-isometric relaxation, stretch the biceps, pull again, and relax, and one more time, pull, relax. Once we have restored supination, pronation, and extension to the elbow, we can then deal with problems at the wrist. Again, we have a complex. It is not one joint at the wrist. We have the carpal radial, the distal radial ulnar, the ulna to the meniscus to the triquetral bone, and all of the multiple bones and joints within the wrist complex. Multiple joints. What we need to do is to restore maximum palmar flexion, dorsiflexion, ulnar, and radial deviation at the wrist. This deals with the wrist as a complex. Supporting the patient's forearms distally, we then introduce and feel for palmar flexion, dorsiflexion, ulnar deviation, and radial deviation, ulnar deviation. We want symmetry of that motion, of all four of those motions on both sides. Treatment principles are directed toward restoration of all four of those motions symmetrically on each side. If we had palmar restriction on this side, we would stabilize the distal radius and ulna, take the wrist and hand into palmar flexion to the barrier, put our blocking hand against the dorsum of the hand, and ask him to straighten out your wrist. Straighten it out. Relax. Following that, we would increase our palmar flexion to the next barrier. Resist again. Push. And stop. One more time. Push. And stop. Had we had dorsiflexion restriction, we would do it just the reverse. We would again stabilize, now take the wrist and hand into dorsiflexion to the barrier, and tell him to push your palm down into my hand. Push, relax. Following the contraction and relaxation, we can take to the new barrier, push, and relax. One more time. Relax. Ulnar deviation restriction, again the same principle. Stabilize the radius and the ulna, grasp the hand and the bones within the wrist, take them in neutral into ulnar deviation to the barrier, and I'm going to want you to turn your hand this direction, Mark, and I will hold it. Turn your hand in, stop. One more time, pull, stop. And one more time, and stop. With radial deviation restriction, just the reverse would occur. Stabilize, stabilize, engage barrier. Take your hand this direction now, Mark. Push out, stop, push out, stop. One more time, and relax. 3 to 5 efforts of this muscle energy are usually sufficient to restore that range of motion. If we have restored palmar flexion, dorsiflexion, ulnar and radial deviation to both wrists, we've accomplished our task of stabilizing and the functional capacity, sternoclavicular, acromioclavicular, glenohumeral, elbow, and wrist. Of major importance in the management of a patient who presents with lower back and lower extremity pain syndromes is to restore functional balance to the muscles of the lower extremity, particularly the muscles governing the 6 movements in and around the hip joint. You want symmetry of length, symmetry of strength, and proprioceptive balance. Now, to test for length and strength, there are a number of different systems available to you. Let me demonstrate for you a simple one that I've found effective over a number of years. This is not a purist sense of each muscle that we're going to test, but the mass action of all of these major muscles of the hip and thigh that are involved in gait and the relationship of the lower extremities to the pelvis and the lumbar spine. We will begin by having Mark lie flat on the table with the head at that end for me. And what we're going to do is to evaluate range of motion of 6 different ranges of motion in and around the hip joint. And we're going to look both for its length and for the strength of the muscle group that contributes to that motion. The first we will start with will be the motion of abduction, and we're looking for symmetry or lack of same of abduction movement right to left. Now, if we have asymmetrical range, we can have 2 different causes of that. For example, if we have less abduction on the right than we have on the left, that could be due to 2 different reasons. One is the restriction of the right side might be because of tightness of the right adductor muscles, the right adductor muscles, or we have greater range on this side because of weakness of the adductor muscles on the left side. To differentiate then, what we would do would be to ask the muscle to contract against resistance and measure its strength. Pull a leg in, pull. That's relatively strong, relax. Now let's test this one. Pull in again, pull, relax. Mark tests out fairly equal in his strength on either side. But let us simulate a treatment for both shortness and tightness as well as for weakness, because the principles are somewhat different. If we had found that there's restriction of abduction on the right side due to tightness on this side with equal strength, what we want to do is to perform a muscle energy contraction of these adductor muscles, and then post-isometrically we will want to stretch them out. Just slide to the right just a little bit, that's fine. Principle will then to keep the knee in full extension, to stabilize the knee and close back. Do not let the foot externally rotate either during the diagnostic or the treatment process. Notice, if you will, if I let it externally rotate, I can get a lot of abduction. You keep it perpendicular, that's the true range of abduction at the thigh here. So we're going to treat this by post-isometric relaxation. Knee straight, stabilize the opposite side, slide my leg in medial to the knee. At the barrier, I'm going to say, Mark, pull your whole leg toward the middle. Pull. An isometric contraction of the right adductors. Stop. Relax, and then stretch. Pull again. And relax. 3 to 5 efforts again of isometric contraction, a post-isometric relaxation stretch should enhance the range of motion of abduction on this side. Had we found that there was greater range on this side, the left side, because of weakness of this group, we would want to strengthen these adductor muscles by a series of concentric isotonic contractions. And let us simulate what that would look like. Again, stabilize the knee in full extension. Do not let the leg externally rotate. Take it to full range of abduction and ask him now, pull the foot toward the middle. Pull it in, activating the adductors. Give resistance to it. Keep going, full range, and relax. Take it out to the full range of abduction. Pull again. This time I offer more resistance, making the left adductor muscles work harder. Keep coming, Mark. Keep coming. Full range. Stop. One last time. Pull with, again, more resistance. Make that muscle work harder each time, but do it through the full range. To test if you have been effective for the shortness, you would expect normal range. If you would then increase the strength of this side, when you strength tested it, it should be symmetrical with the opposite. Those principles of either stretching the tightness or strengthening the weakness are applied to all of the other movements in and around the hip and the thigh. The next movement to look at would be adduction movement, to test for the length and strength of the abductor muscles on the side. We're going to test the adduction movement of his left side for range, quality of end feel. Range, quality of end feel. If we find tightness of the abductor muscles on this left side, we would go to the barrier of adduction motion, push the left leg out. Mark, push, make it contract isometrically, stop, stretch, push again, push, stop, stretch. This leg that I'm holding on the right side is just stabilizing his pelvis as we work his left leg. Push it again, push, relax. If we wanted to strengthen the abductors on this left side, we would take it to adduction and tell him to push the leg out to the side. Go, 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 go. Full range. Stop. Do it again, this time with more resistance. Keep going. Full range. Stop. And again. More resistance, we make it work harder each time. So we would restore balance of the abductor muscles with their length and strength. The next muscle we would look at would be hamstring length. Now, straight leg raising includes more than hamstring length, but to monitor the length of the hamstring, we put our fingers on the opposite anterior superior iliac spine, flex the extended leg until we first feel the pelvis move underneath my hands on the right anterior superior iliac spine. That is actually the hamstring length. Switch hands and compare the opposite side. If we find restriction of straight leg raising due to hamstring length, and we wanted to stretch a hamstring, and you will many more times want to stretch hamstring than strengthen them, but to stretch the hamstring, we would do it in the following fashion. Put the heel on my shoulder. I'm going to control hip flexion and knee extension till we get to the barrier to the hamstring. Now, Mark, pull your heel down to your buttock on the right side. Pull it straight down. And stop. Following isometric contraction. Stretch it a little more. Pull down, pull. Relax. Get to the barrier. Pull down one more time. Relax. And then stretch the hamstring out. And then go back and retest again. The next group will be that of internal and external rotation at the hip in the 90-90 position. We have 90 degrees of knee flexion, 90 degrees of hip flexion, and in that position we're going to test the capacity of external rotation and internal rotation, movement, range, quality, and end feel. Now, internal rotation of the femur in this 90-90 position puts the piriformis on stretch. That is the piriformis length. Very important muscle in patients with low back and lower extremity pain syndromes. Come to the opposite side, internal, external rotation. This is internal rotation of the hip. The anterior surface is turning medially, internal rotation, and external rotation. Now, the one that you'll treat the most of this group will be tightness of a piriformis. And the way you would do that would be to assume this same 90-90, found restriction of internal rotation. So you want to maintain that, put a little adduction movement in. That puts both the adductor and external rotation function of the piriformis on tension. And then the resistance would be in the following way. Post-isometric relaxation is our principle here. Pull the foot toward the middle, Mark. Pull it in. That's external rotation. Resist that. Stop. That's one of the functions of the piriformis, external rotation. Pull again. Stop. The other function is abduction function, and we have him do that by push the knee toward me. Now, Mark, push, relax. Actually, you get a little bit of each of those abduction and external rotation with each effort. But do a little of both, whichever seems to work the best, and always stretch after each activity. Had we wanted to strengthen that piriformis, we would start here. Push the foot out toward me. Push. Keep going, keep going, keep going, all the way. Stop. Push again. More resistance. Keep going all the way. And one last time. All the way. The internal rotators are seldom in need of treatment in that position. Having done abductors, adductors, hamstring, and internal and external rotation in the 90-90 position, we'll now ask Mark to roll over on his stomach. And now we are going to test for quadriceps length. This one we can do simultaneously. Flex the knees, both hands symmetrical, and the one that goes the farthest is what you're looking for. In Mark's instance, we've got tightness of the left quadriceps. Now, to make sure that this isn't due to weakness of this right, I'm going to ask him, straighten out your knees, Mark, push. And that feels symmetrical to me. So he has symmetry of his length, of his strength rather, symmetry of his strength. So I know I have tightness of the left side. To treat that then, I must resist knee extension, quadriceps action. Put the foot on my shoulder, hold the table. This is a very powerful muscle, and you have to put a lot of resistance against it in order to accomplish your task. Straighten out your left leg, Mark. Push. Relax. More knee flexion. Push. Relax. And one more time. Push. Relax. And stretch. We should then get symmetry of knee flexion as an outcome. Had our abnormality been weakness of this right quadriceps, all I would have done was say, all right, straighten out your leg. Keep going. Go, 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 go. Full knee. Go. Straight. Good. Let me have it again. More resistance, second effort. Go, 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 go. And relax. Again, 3 to 5 reps of full range. Again, go, 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 go. Recruits more firing within the muscle, strengthens the muscle physiologically. In this position, we then test internal and external rotation in neutral for the hip joints. So that would be internal rotation. And then to test external rotation, we stabilize one side, test this one. The first movement of the pelvis is due to external rotation at that hip. Stabilize this side. Now, this internal rotation maneuver tests the other 5 external rotators of the hip joint, other than the piriformis, which is the 6th one. Have we had restriction of that on, let's say, this right side, we would treat that by having him push his foot toward the middle. Push toward me, Mark. And stop. That's an external rotation effort that we are asking the external rotators, obturator internus, externus, gemellus superior and inferior, and the quadratus femoris, to push the knee toward, push the foot toward me. Push toward me. And stop. Always going to the new internal rotation barrier and push again. Relax. Same principle will be applied if we had found resistance to external rotation. We would stabilize here, push the foot out toward me this time. Resist, post-isometric relaxation, stop. One more time, push, stop. So now we have done the abductors, adductors, internal, external rotators, both in the 90-90 and in the neutral position. We've done hamstrings and quadriceps. The last muscle we would now test would be the psoas. If you'll roll over on your back for me and slide down to the end of the table for me, Mark. All the way down, all the way down. Now, take and hold your left knee. Bend it up and hold your knee. And let me take you back down to the table. Lie back. Now, you never want to test this muscle until you're sure you have pretty good lumbar function, because you can put the lumbar spine into considerable stress doing this maneuver. What we want to test for is the length of the psoas, and we will do that now. He's flexed up his left leg, holding the pelvis tightly that way. We now passively extend And what we're looking for is the capacity of this leg to extend sufficiently to get the back of the thigh to the table. If it doesn't get to the table, then we have shortness of the psoas on this right side. To test the other one, we'll just have Mark change his hands, keep the right knee tight, and then let me take the left one down, and we do the same procedure. Now, let us suppose that we had found shortness of this right psoas. Hold the other knee. How we would treat that would be as follows. We'd ask Mark to stabilize the pelvis by keeping the non-symptomatic leg fully flexed. I would passively extend it down to the first extension barrier, stabilize the leg, in fact put a little internal rotation to it, and then resist, lift the right knee to the ceiling. Mark, lift, stop, then I would stretch it down. It's important that he maintain this all the time. Lift that right knee again, right knee up, and relax. A little icing on the cake is, as you lift it this time, pull the foot toward the middle. The right foot, that's good. And relax. Once we have tested for and evaluated length and strength, treated them symmetrically, both sides, with whatever is appropriate, either a multiple repetitions of isotonic contraction for a weak muscle or a series of post-isometric stretches, whichever is appropriate for each of those groups of muscles. But you want to make sure that you have restored symmetry as best you can so that the muscle imbalance doesn't cause your dysfunction within the pelvic girdle, lumbar spine, and the rest of the trunk to recur because of that abnormal motion.
2 times.